So much for listening to this episode of Earrings Off. We want to invite you to subscribe, rate, and leave us a review. You can find us on Facebook at Earrings Off Podcast and on Instagram at The Earrings Off Podcast.
Welcome to Earrings Off. I'm Lou.
And I'm Teresa. Let's get started. In just a couple of minutes, you'll hear a really compelling conversation that Lou and I had with Dr. Eugene Manley. But first, indulge me while I introduce our guest. Dr. Manley is a cancer scientist, health equity leader, and longtime patient advocate who works at the intersection of biomedical science, cancer care, AI ethics, and leadership. His background is deeply rooted in lung cancer research, but his work today goes far beyond the lab. It's really about how people experience healthcare in the real world. He's the founder of a nonprofit focused on cancer health equity and the force behind an annual lung cancer summit that brings together patients, clinicians, researchers, and industry leaders. What really stands out about his approach is that patients aren't just invited to listen. They're part of shaping the solutions. One reason I am so happy to have Dr. Manley on the show is his commitment to patient advocacy. He believes and teaches that patients deserve to understand what's happening in their care, to ask hard questions, and to be treated with dignity and respect at every step. That perspective comes from years of listening to patients and walking alongside communities that are too often overlooked. So, if you care about patient equity and being an empowered patient within our complex healthcare system, you're in the right place. Please keep listening.
Hello, everyone. Today we are super excited to have with us Dr. Eugene Manley. Dr. Manley, welcome to Earrings Off.
Thank you so much for having me. It's a pleasure to be here.
So we're going to jump right into the questions, Dr. Manley. You've worn so many hats: career scientist, nonprofit founder, and patient advocate, which I totally love. When did this work shift from a career to a personal mission that led to the STEM and Cancer Health Equity Foundation and the annual Lung Cancer Summit?
You know, that's a very good question, because if you had asked me growing up, was I going to launch a nonprofit and run a nonprofit focused on lung cancer, I would have looked at you like you were crazy. Mm-hmm. If you had asked me this 5 years ago, I still would have also looked at you like you were crazy. You know, I grew up inner city Detroit, first gen, and I just saw what my family went through navigating care, and then how, you know, my mom would go to doctor's appointments and stuff would be in my chart, and then you couldn't understand it and read it. And then they called me and asked me to interpret stuff, and then the directions would be on page 5. And you're like, patients aren't going to get through the jargon to read the instructions if you don't take the time to explain it to them. And then my PhD was in lung cancer. So I did a lot of lung cancer research, but I wasn't doing disparities at the time. I was just doing drug resistance. And so we weren't even thinking about disparities in early 2000 because we didn't even have biomarkers discovered yet. Mm-hmm. But then as I transitioned out of the postdoc and into the nonprofit space, I worked at a major cancer org and 2 lung cancer orgs. And then at the second org, Lung Cancer Research Foundation, that is when some minority patients started reaching out to me to ask me to develop content and programming around disparities in lung cancer. And so then I started speaking more about it. And then as I transitioned to longevity, more people asked me to speak and develop stuff. And then what I just saw was that there was just a significant lack of information out there for Black, Hispanic, and other underserved communities navigating lung cancer. While there were great lung cancer orgs, there just was not much specifically targeting those communities. And I said, okay, I have a skill set and I'm an engineer and I know how to speak. It was sort of out of that need that led to the creation of the Sheck Foundation. So part of our work is, trying to educate patients about navigating care, advocating for care they're entitled to. Part of it is trying to help diverse kids know they can go into STEM fields at early ages and helping them navigate those career transitions. And then that last piece, which is a title one, is that Lung Cancer Summit, where we wanted to bring the patients, researchers, and clinicians in the same space so the patients learn more about the disease, learn more how to advocate, and learn who is working on their behalf, whether locally or nationally. Because, the biggest challenge for Black patients is we don't get the same information. And then we bring in all these different researchers, payers, et cetera, to talk about what they're creating that are actually removing the barriers. So the conference is about solutions, not just problems. And that's what makes it unique.
Wow.
Okay. Well, I tell you, Dr. Manley, years ago, I used to be a medical social worker. And I understand what you're saying about many times patients not understanding and the information that's in the chart, them not being able to process. And a lot of times I would have counseling sessions with the family members to just say, when your mom's in the hospital, not only do we need you to show up, but I need you to be able to understand what's going on. So, and not be intimidated by the doctors. Many times I would sit right there. I would communicate to my team members about the need for the patient to understand before discharge so that they could follow up and get better. So I applaud the work that you're doing. But as a cancer scientist, you've spoken about experiencing medical racism after surgery. So, can you talk to us a little bit about what happened and how it shaped your understanding of how bias, documentation, and communication affect patient care?
Yes. So I had my fair share of just a medical racism, just looking at how my mom was treated in healthcare interactions before she died. And, she be in a hospital and then they have notes on the wall, she's, leave her lights on because she had this horrible fear of dark, but they would cut her lights on and just be mean and snippy. And it was ridiculous. And so in my instance, I fractured my ankle at the end of 2024 in a slip and fall. And I was in a boot for 7 weeks. And then I ended up going to have reconstructive surgery after the ankle fracture healed. And while I had great alignment with the podiatrist who did the surgery, and he knew I had a biomechanics background, the issue was never him. It was the rest of the hospital staff decided that, oh, this one's poor, Black, and on Medicaid. Now, mind you, I'm on Medicaid because I launched a nonprofit, not because I'm poor. Well, I guess I am, but either way, that doesn't really matter. You shouldn't decide how you're going to deliver care to a patient based on what you perceive their education or insurance is. But so while we had a robust plan and I was supposed to go to skilled nursing, the physical therapist decided that 36 hours after this surgery, when she came in the room and had horrible bedside manner, that she would document in a chart that I had no pain and could ambulate. Now, mind you, triple arthrodesis, bone fusion, this is a non-weight bearing surgery, supposed to be non-weight bearing for 6 weeks. Wow. So I don't know how you write in a medical chart 36 hours after the surgery, the patient has no pain. And then the OT agreed. And then there was a nurse that tried to give me an early discharge notice that Saturday evening, which is less than 48 hours after surgery. Now, I had no follow-up with the surgeon yet. I had not seen a caseworker or a social worker because, they're not around on a weekend. Yeah. And then this was given to me at 6:30 p.m. And I remember this. I mean, I was out of it on the drugs. Not good drugs, but I was out of it, but I was alert enough to know, like, I'm not signing this. And so the nurse wrote in there, patient refused to sign, and then wrote the relationship itself and said, I didn't sign this, so no. And what made me upset was that it had been back timed. It was already time for 9:30 a.m., but they gave it to me at 6:30 p.m. Now, according to law, you have to give a patient a discharge notice 24 hours in advance. They're trying to write one thing and then try to chart it one way. And I said, no, this is not acceptable. Finally, when my proxy called and yelled at them, And so I was labeled a trouble patient. And then the hospital list 3 days later was asking about my ability to pay for skilled nursing, which is absolutely not her job. The surgeon wanted to have PT do a reassessment, and they avoided answering the surgeon for 5 days until he finally complained. In that time, because PT, which I did not know, had wrote patient can ambulate and has no pain, we were denied skilled nursing. And even though the surgeon tried to appeal peer to peer, and the insurance person was just surprised by what was written, because PT had said had no pain and can ambulate, we lost the appeal. And if the surgeon hadn't even appealed for some homemade services, I would have gone home with none. Though the hospital staff said, well, if you go home, we'll get you homemade services. So you had continuously misrepresented and lied and fabricated that whole time. And I didn't realize that they had lied until probably 3.5, 4 weeks later. I'm still in extreme high amounts of it, but I'm starting to read the medical records. Because, when you're in the hospital data, you should not expect to have blatant falsifications in your chart. It was really harrowing. And then I'm in so much pain. And I don't know why you have someone that's 300 pounds hop on one leg with a walker, even though they're non-weight bearing and they're on all these pain meds. And lo and behold, I have no pain and can ambulate, but I'm getting Percocets every 4 to 6 hours for like 6 weeks. And then even on discharge, they said, oh, patient has a caregiver, which I don't, which was the sole reason we were getting skilled nursing. I've never seen something so egregious in my life. And it wasn't that I was naive to think it would happen. I'm just sitting here in disbelief because they completely disregarded me and the surgeon. And because he didn't have direct admitting privilege at that specific Mount Sinai hospital, they could do that. And so it really reinforces why I try to teach patients how to navigate care, how to make sure you have a medical proxy that can read your records in real time, and teach them how to file complaints with hospital leadership, and then, agencies that regulate physical therapists. So there's a whole bunch of stuff I created that can help people navigate care.
Well, I tell you, in listening to you, Dr. Manley, that is so unfortunate that you went through that. But then I'm thinking, of course, if you went through that, what are other people experiencing? That's the
Exactly.
scary thing. I remember when I used to be on the kidney transplant unit, dialysis unit. They would put in the medical records that the patient was non-compliant because they couldn't come in for dialysis. And after I would speak with the family and speak with the patient, it wasn't that they weren't compliant. They didn't have transportation 3 times a week. When I finally got to the point where I could speak to my colleagues about that, no, Miss Jones is not, she is not being non-compliant or difficult. She doesn't have the resources. So if you would help me develop these resources for patients, then you're going to get a better outcome. I experienced that as a medical social worker.
And that's the big challenge. It's, how do you navigate when you don't know? And that word non-compliant is so bad because it's used to dismiss typically you're poor and underserved when you not bother to ask what are their barriers and challenges. They can't just drive in. They may not be able to take the bus. Like, are you helping meet them where they are? Are you just checking?
Exactly. And there are instances where, the big thing is when a patient leaves the hospital against medical advice and everybody's upset about that. But when you've been disrespectful to this patient and they've had a horrible experience and they don't trust you and they're not feeling well, then you label them as, they're leaving against, well, actually, you drove them to this point because they feel overwhelmed. And like I said, sitting here listening to you, if you experience that, it is just scary. It really is.
Yep. How many other poor, underserved patients are pushed out of that hospital after surgery early, and they don't even know why they're pushed out early, and then they end up with readmissions or other injuries because the hospital is obsessed with length of stay or, their ratings. And I'm like, well, what quality do you have? And, and it's really disingenuous when on the one hand, when you're a joint commission accredited hospital and you want people to come do clinical trials, but then when you see people at their worst, you treat them like subhuman detritus. Like, so why you can't have it both ways.
Yeah,
Right. Yeah, and I don't want us to miss that. You don't have to be poor. I think you said that in the beginning, for this type of thing to happen to you. It's just
It's
a
a
matter
bias.
of, it's a bias, right?
Yeah.
So I want to ask you a question. I mean, I want to make a comment first. It's a question to both of you, actually. Did you guys hear this week that ChatGPT is releasing a new chat health bot? Okay. And the purpose of this bot is for individuals to be able to upload their test results and then ChatGPT do some analysis on that data, right? Did you guys hear that?
I did not.
I
Yeah.
only vaguely, literally saw something across my LinkedIn feed maybe an hour ago, but I just saw it, but I didn't literally go a deep dive. So this is
Yeah.
Yeah.
my first time really hearing.
So that's
Didn't know.
coming. That's coming. So with that, I want to ask you this question. I understand that AI has become more embedded in cancer care. Where do you see it truly reducing disparities for Black and underserved communities? And where might it be unintentionally reinforcing them?
Okay, so we'll go first with where it could be reinforcing them.
Mhm.
Think of just broadly, charting and, insurance denials or peer-to-peer denials, just automatic rejections because it's going through the AI bot. You could have someone, let's say they've done a study supposedly to look at dense breast and linkage to breast cancer, and they've used this AI system, but they've done their test data all in European women, but you say, oh, we have this great product, and you did not understand the part that Black women tend to have dense breasts and are at much higher risk of breast cancer. So you're going to push out something that clearly does not work for the population that has highest incidence. And this happens a lot when we adopt things without due diligence or having people from that community or from that background on a design team, implementation team, or assessments team. Now, there is, and I'm not saying this is the only example, but there is a positive example of something that was not designed on a diverse population that actually has worked. There's an AI algorithm called Sybil, Sybil, and basically it was used to look at patient low dose CTs from the lung cancer screening trial, which is sort of established that we should be doing screening as a indicator of lung cancer risk for those that have a history of smoking. Now, the data set in the lung cancer screening trial was not diverse at all, but the bot was still able to look at scans of someone up to 5 years before it could sort of see, predict that they would have lung cancer. So
Wow.
in and of itself, okay, that's a result. Okay, how do you show it really applies in broader context? So what they have done is they also have used this AI at the University of Illinois Cancer Center, which is a FQHC, which has a very diverse and poor population. And they were also able to show pretty good ability to predict lung cancer up to 5 years in advance based on a low dose CT. And then they also showed this in a South Korean data set. So two completely different populations. So this is where you can show that something that does not work, well, was not necessarily designed for underserved, but you can implement it and show that it has potential to work. So I know now they are working to look at other high-risk populations that aren't eligible for screening. So like people, like firefighters, those with indoor cooking modules, job exposures, radon. So they're trying to set up other parameters to see if this can work, because right now the only eligibility for lung cancer screening is that you have to have a 20-pack a year smoking history.
Would you just talk a little bit about the indoor cooking modules? What do you mean by
So,
that?
so
A regular,
basically,
okay, go ahead.
so think of it like, a lot of times you're in the house, you're cooking with oils and stuff, and the stuff is coming aerosolized. And if you don't have an exhaust vent, that means all that aerosolized oil, even though you don't notice, is going in your nasal cavity and going down. And so all that stuff can, lead to lung cancer. We think about air pollution or people living by freeways. These are all things that can lead to lung cancer, but they aren't officially in the screening guidelines. But we have data that show, people that work with, fire and fireplaces and, those things have higher
Mhm.
risk. And we're starting to have data that shows that.
Okay.
Mhm.
All right.
Okay.
Thank you.
Dr. Manley, you just referenced an acronym, FQHC.
Yes.
Okay, and what is that?
So that's a federally qualified health center.
Okay.
Those are typically in poor, underserved communities. They tend to have a diverse population. They
Mhm.
tend to be uninsured or underinsured, and they're often safety net
Okay.
places.
Okay. Wow. Lung cancer disproportionately affects Black and low income communities. Based on your work, what are the top 2 to 3 changes at the system or clinic level that would most quickly advance lung cancer equity, Dr. Manley?
Okay, this is since I do this kind of work, I can give you several. One is we need to make sure that patients get offered all the biomarker testing upon a diagnosis. Right now, we have roughly 11 biomarkers for lung cancer, but most people only get 1 to 3 of them. So if we could get all the biomarkers testing or next generation sequencing, which would capture them all, it would be great because then you could identify if there's a potential therapy for them that they can go on earlier as opposed to playing, oh, well, we're going to only give you this. And then you have something you could have, possibly spared their, giving them more time. The
Hmm.
other thing is we need more representation in clinical trials. I think lung cancer clinical trials, I think a report maybe 3, 4 years ago showed that of all these therapies that have come out in lung cancer, the participation of Blacks in these trials is less than
Hmm.
3%.
Hmm.
So this goes on a level of what are the trial sites doing? What are the coordinators doing? And if you only come into a community to do a
Right.
trial, but you have not done any other education
Hmm.
or outreach, or
Or
if you don't have your
engaged.
coordinators that look like that community
Hmm.
or understand how they communicate, then why would they trust you? And so you can't just say, "Oh, come, we have a trial, we can help."
Yeah.
No, that's not going to fly. Uh,
Right.
and I think the third thing is more upstream. We always talk about trials and trial diversity, but I think about, well, what kind of samples do we have? And I worked on a paper with some people, and we showed of all the lung cancer cell lines available, of over 800 cell lines, there were only 30 cell lines from Black individuals, and only one was a non-small cell lung cancer cell line. And so, if our starting materials, which often are used to develop therapies and screening and then therapies that go into patients, if our starting materials don't reflect the patients with the disease, then we have to be worried that, of course, the stuff that we're going to produce may not impact those communities at all.
Mhm. All
For
right.
someone who's just heard you might have cancer or you need more tests, what key questions should they ask their team to get clarity and protect themselves so they make better decisions?
I think, when someone gets cancer, it is such a gut punch and
Yeah.
it's deflating. And you have so many thoughts going through your head. And they will give you this massive booklet on stuff, and you are not going to process or read it because you're like, well, is my life over? What about my
Yeah.
family? Do I
Right.
tell my job? Am I going to lose my insurance? So if you can get through that, I think you really one need to know if there's a nurse or patient navigator at that site. Because if you have that, your life becomes a lot I wouldn't say easier, but it comes more manageable because then you have someone you can directly ask questions to.
Hmm.
And then you have to ask, what kind of, what type of cancer it is, what stage. Then you ask, well, what other tests are needed? You know, are we going to do a therapy or is there a trial that you can go on? And then, what is that process like? And then, what is the expected outcomes? What are the measurables? And then if it is a trial, you can ask, well, you are within your right to ask, would you put your own family member on this trial? You are within
Hmm.
your right to ask it. If the doctor cannot answer that, you don't want to be on that trial.
Hmm. Hmm.
Mhm.
Wow.
I like
Okay.
that.
Yeah. Yeah. Dr. Manley, after mentoring for over 20 years, what guidance do you give students or early career scientists who want to work in cancer and health equity but feel discouraged or shut out by the system?
This is an interesting question because major systems tend to be resistant to change and they will market and say they do diversity, but then when you get there and you're the only one, you still have to do sort of the company line or the
Mhm.
research line. So it's hard to really advocate for diverse and underserved communities until you get to a leadership position. And then you still have to be very careful how you push and advocate for that because if you push too hard, then you get labeled as a troublemaker and then
Right?
you have a hard time getting references and moving on. And so I would say, and especially in this environment right now, it is really, really hard to do work in underserved communities and get funding for it. That is a challenge. But I would say if that is the path you want to go, try to find someone that is actively working in that space that is still receiving funding, whether it's federal or under mechanisms, and then learn and work under them and try to find the conferences because there's still conferences that focus on disparities and then network at those meetings and then find other people. Just be inquisitive, ask questions. There's also two meetings they should consider. SOCNUS, which is the Society for the Advancement of Chicanos and Native Americans in Science.
Hmm.
They have been around a little over 50 years and they have an annual STEM conference and it's geared for undergrads, grad, postdocs, etc. And they have a lot of inspirational speakers. They have mentorship. They help you see different careers. The annual biomedical research conference, ABRCAMS, annual biomedical research conference for minoritized scientists, which is run under the American Society of Hematology. They have ABRCAMS, which is more focused on Black students. It used to primarily only be grad students, but they've now started to go back to undergrad students and a little more. But it's been a rough year for them with funding as well.
Right. Right. Okay. Wow.
I just want to know, how do you stay grounded and what practices do you recommend for others who are doing equity work?
This is actually a very good question because, I work to try to address structural and systemic issues that keep students from going into STEM, advancing in STEM, and communities from, getting care they need. So you have to understand one, there's so many problems to fix, and that you alone cannot fix them all. That's the first thing you have to.
Mhm.
You cannot fix everything.
Right.
If you think of health equity, I think of it as intentionality. It is, addressing a barrier or a challenge for a group or groups so they get the same outcome as the majority. As opposed to trying to pick 12 problems, pick one problem, figure out what the problem is, what are the barriers, what's the solution, implement something, show you can do that, and then try to scale that. And then once you get that done, then you can go to the next problem. Because other problems are going to be there, but don't go trying to solve everything because that is a recipe for burnout and failure. And then, and there's already enough mental health when you're Black in the
Yeah.
country dealing with all the other things that we don't
Yeah.
often routinely talk about.
Yeah.
Yeah,
Yeah.
that
Okay.
is true.
Very true.
Well, Dr. Manley, we've reached the end of our questions. What thoughts or words of encouragement do you have to leave with our audience?
I want the audience to know that No matter where you are, you deserve to be treated with respect and dignity, and you deserve to be listened to, and you are within your rights to ask for these things. That is the key thing I want people to take away. And that if they are trying to reach out, our socials are STEMMCHEQ for Facebook, Instagram, and LinkedIn, and then they can follow me on LinkedIn with Eugene Manley Jr., PhD. And if they say they watch the podcast and they send me a message on LinkedIn, I will send them a 2026 patient power playbook. So just 7 things you can ask in your healthcare setting that will help them as they're navigating care.
Oh,
Thank you
wow.
for that. You've shared a wealth of information with us today. Thank you for taking the time. All the best to you and your foundation. You take care.
Thank you so much. It was a pleasure to be here, and I hope this is informative for your audience.
Absolutely. Thank you.